here. Oh my goodness. Oh no, it's no, you just have to. Oh, yeah, yeah. Okay. All right. Um, is everybody able to hear us? If somebody can just put in the chat if you can hear us.
We can hear you.
Yes, I can hear you. Thank you. All right. And we are good to go. Thank you, everybody, for your patience. Thank you, Chris.
Okay. This mic works fine.
This is for our room.
Okay.
And the computer will be for everybody that's remote.
Okay. I need a water. Okay. All right. Well, I hope this is not a harbinger of things to come. So let's get started. So my name is Sharon. I'm one of the Palm Crit residents, fellows here. And I'll do the first presentation today, IV fluid therapy in the ICU. I guess I feel kind of lucky. It's me going first, so we don't have any real, So, all right. So our objectives today. One more thing, I tend to speak really fast sometimes when I get ahead of myself or when I get nervous. So please feel free to tell me slow down. And I tend to speak soft sometimes. So feel free to tell me speak up. So today we'll discuss the rationale for IV fluid therapy in the ICU. We'll review the physiology of fluid resuscitation in the patient, primarily in the patient in shock. That's what we most commonly see. We'll discuss fluid management in the different phases. And we'll review the available evidence or lack thereof to guide our choice of fluids, colloids, crystalloids. And did something happen? Oh, colloids and crystalloids, and of course the new, hot kids around, the balanced crystalloids, basically. So basically, as an introduction, IV fluid therapy, of course, is one of the most common interventions in an acutely ill patient. Annually in the US, a staggering amount of more than 200 million liters of fluids is used annually. In the critical care patient itself, which we take care of, more than 20% will receive IV fluid therapy in the first few hours in the ICU. If you have to think about it, IV fluids have been around for like centuries. So it actually started and entered medical practice during the cholera pandemic in Scotland in 1832. And you'd be surprised to know how it actually came around and then has since been kept in medical practice despite a robust efficacy data. So it was proposed then as a means of restoring blood to its natural specific gravity and restore its deficient saline matters. And at the time, it was really based on anecdotal reports. So this physician, O'Shaughnessy, noted that a patient who was dying of cholera, who looked very blue and was literally dying, they injected a weak hypotonic saline solution, which was basically water, chloride, and bicarbonate in small aliquots into the vein. And as he added more saline into the vein, the patient, you had this most wonderful and satisfactory effect, which was the patient basically no longer looking blue, but starting to get a little bit color. Of course, the patient died a few hours later. And that's principally because the patient was already literally exsanguinated, because that's how they treated cholera back then. They had no idea what it was about. It was at least 20, 30 years before John Snow came about and figured it was the Thames River contamination. And so basically, first thing they did was they exsanguinated you because they want to take away the bad blood and relieve the venous stagnation. So they exsanguinated you, they gave you some cathartics to give you diarrhea, and then thought, let's try some IV fluids. So that didn't really work too well. And so typically our current rationale, of course, is to administer IV fluids, typically as a bolus to restore for resuscitation, and of course to maintain the extracellular volume and electrolyte balance. The most common indications of fluid resuscitation, if you look at a 2007 international survey, was impaired tissue perfusion with low cardiac output and abnormal vital signs. That hasn't changed so much if you flash back to maybe 2016, where in the US ICUs, the most common indications for IV fluids was actually hypotension, low CVP, and oliguria. And of course, we all commonly know that this is what we see in patients in shock, and that's of course our knee-jerk. You call with the hypertension, fluid bolus. You call with low CVP oliguria, let's try fluids. So it's not entirely uncommon that that's our go-to thing. So of course, that's going to be indicative of hypovolemia, but we have to recognize that both hypovolemia and hypervolemia are associated with increased morbidity and mortality in the critically ill patient that we take care of. Obviously, this patient that with bolus fluids for the low CVP and what have you now could become fluid overloaded pretty quickly if we know. And of course, we define fluid overload by more than 10% weight gain compared to admission. In the large septic shock cohort, more fluid balance at 12 hours and cumulatively at 4 days. This is really, really associated with poor prognosis and increased mortality. And so we really want to be careful with the amount of IV fluids we give. That's very important because if you look at this slide, which is from the Agency for Healthcare Research, in 2018 alone, if you look at the most common ICD code for the hospitalized patient is septicemia. And that's basically what we deal with every day. If we don't see it, we look for it. So that's kind of like our bread and butter. So it's important in these patients that we're trying to resuscitate them to avoid a volume overload. We keep in mind the different phases of shock. So of course you have your 4 phases, your salvage phase, optimization, stabilization, and your de-escalation. And based on where you are at in these phases, you want to make sure you can optimize your fluids, not just your type of fluids, but your volume to actually prevent worse outcomes, either in terms of under-resuscitation and of course with over-resuscitation as well. So I may just skip a few things in the interest of time. Over-resuscitation is of course important, particularly in the subset of patients we see in the ICU. If you look at a study that was done in 2006, where we combined 2 fluid management strategies for acute lung injury, where you have a conservative fluid strategy actually is associated with shortened duration of mechanical ventilation and shortened duration of ICU stay, although there's no real mortality benefit. So obviously, fluid management is important, not just for your septic shock patient, but of course, patients in ARDS. And very commonly, the two are the same, septic shock, now you have ARDS. So these things are important to manage. And so we talked about the importance of IV fluid itself in terms of the amount of it, but the bulk of this talk is going to be about the actual choice of fluids. What do we really use? And so we are going to use crystalloid. We're going to examine the data for crystalloids and colloids. Crystalloids, of course, normal saline balanced crystalloids. This is just one of our beaches at my home. Maybe towards the end, you'll see a better one, I think. So at least my favorite. So we don't have that option, of course, this kind of salt water here, I guess. So crystalloids was a term introduced way back by Thomas Graham. And that was actually just used to describe a solution that could be crystallized with ease, and that usually contains salt, urea, or sugar. And it contained ions which were capable of diffusing across a semi-permeable membrane. And of course, we divide crystalloids in 2 basic types: our normal saline, which has been around for like centuries again. Most people have said now it's not necessarily considered normal saline, but that's our go-to thing. And of course, the newer, not newer, sorry, but the class of what you call balanced or buffered solutions. And we use to change kind of the terms balanced and buffered sort of like interchangeably. They kind of mean about the same thing. And really what it contains is that it contains sodium, potassium, and chloride, so other ions, which normal saline does not contain, which is a little bit closer to the extracellular fluid content. And so we have, most commonly, we have ions such as lactate in there, so lactated ringers, we have acetate and gluconate. That's what we typically find in ringers, acetate and plasmolite. And so if you can take a look at the composition of these fluids, if we look at on this panel on the far left, you have your plasma sodium, of course, 135 to 145. If you look at plasmolite, is about 140. If you stroll all the way down to normal saline, it's like actually 154. So that's something that most people have said it's not as physiologic as we'd like to think. And in the middle, we have different types, plasmolite, normal sol, and what have you. If you scroll to the middle, where I have also highlighted the chloride content, that's been heavily scrutinized over the years as a cause of the increased adverse side effects, probably, what you would say, adverse outcomes, sorry, associated with saline, and that's the content of chloride, which is far higher than, say, than plasma, of 94 to 111. Normal saline actually has 154. So again, normal saline, like I said, has been around for like centuries. In 2010, it was identified as the most used crystalloid. Of course, we've mentioned this chloride content, which is what's becoming a big issue and it's been a focus of studies and discussions of late. It has been around so long that in 1983, there were experimental studies in dogs that showed that hypochloremia led to renal vasoconstriction, which could certainly impact a patient's renal function, in your ICU. In 1998, we have studies which was also preclinical, meaning not in randomized studies or clinical practice, which showed that there was also effects on the acid-base balance. However, it was not clear how this acidosis that was generated contributed to organ dysfunction and or survival and clinical outcomes. We do know that in healthy humans, saline infusions can cause decreased renal blood flow, blood flow and urine output, and these studies have been around from early 2000s as well. Lots of retrospective studies which showed that there are adverse events associated with normal saline. In terms of, I'll just try to scroll through some slides in the interest of time as well. In addition to retrospective data, we also had other propensity matched analysis of patients with, for example, septic shock, where you saw balanced crystalloids was associated with 3.2% lower absolute risk of in-hospital mortality, and that was early in 2014. Particularly if you look at large volume resuscitation, that is defined by any person receiving more than 60 mL per liter in 24 hours, the high chloride load associated with it associated decreased 1 year survival. So that's all good, food for thought basically. And so this is just to compare your normal saline versus your balanced solutions. As you can see, normal saline is associated with cardiovascular effects and of course renal abnormalities. They have proposed that they could be saline can cause hypotension, for example, in your septic patient, decreased microcirculation, and of course, increased inflammation. So again, more food for thought. So that led to a number of the small studies that you might be familiar with when we are looking at IV fluids and the choice. So the first study we're going to look at is a split study, which is basically a comparison of Plasma-Lyte or saline. And that was looking at balanced solutions versus saline in the ICU. So the question they asked really was, does the use of balanced crystalloid compared to normal saline affect the incidence of acute kidney injury? And so, like I said, it was basically a study of Plasma-Lyte versus saline. So you have to keep that in mind when you're trying to compare fluids. So you cannot necessarily say, I'm going to extrapolate, this is the same as, say, LR versus saline. So compared to saline, Plasma-Lyte, that is a large randomized controlled trial performed in New Zealand in 2014. Over 2,000 patients. If you notice here, they were not very sick, so a Apache score about 14.1, so I'd say moderately ill patients. But that study was only done, or predominantly fairly healthy patients, in the sense that they were like patients who came in for surgery. So somebody who comes in, from home for cardiac surgery, they went into the OR and they admitted them to the ICU thereafter. And they received only just about 2 liters of IV fluid in both groups, and that's way under what our normal ICU patient will get. What they did note was that AKI, based on Rifle criteria, there was no statistical difference. So we compared Plasma-Lyte with normal saline in a group of patients who were moderately ill post-op surgery. And again, there was no statistical difference in the risk of in the incidence of AKI, requirement for IRT, need for mechanical ventilation, length of hospital stay. Like I pointed out, the study limitations, majority of patients were post-op to 71%. And if you look at it, there's only 15% of patients who came from the ED, nothing like what we see in our typical large ICUs here in the United States. And of course, throughout the entire ICU stay, these patients only received 2 liters of fluids. And like I said, you go through that in the first, half hour of hitting the hospital doors. So it's not a study that you can necessarily use to generalize decisions or make decisions. The bottom line was, in the study of patients, moderately ill patients, there's no increased risk of AKI when you compare Plasma-Lyte compared to normal saline. So moving to the SALT ED trial, I put this one there because there's been a bit of debate as to whether this could be another study we could use to justify our choice of IV fluids. That was really a single center study that Vanderbilt undertook back in 2016. And it was just an ED study, really. And what it was looking at is whether patients who come to the ED and they are not ill, meaning they aren't going to go to the ICU, if they're going to go to the regular floor, if you give them about a liter of fluids, how well did they do? And again, you could see just from telling you what it was, this is not something that we can use to generalize our decision making either. So if you look at it, it was a very large study, 13,000 plus, with a median fluid volume of just over a liter. And out of that, 95.3% received LR, and 4.7% received Plasma-Lyte. So this study, as opposed to the other one, is mostly a study comparing LR versus normal saline. And the study outcomes, again, no significant difference between the study groups. What they did note was that the balanced crystalloids from that study, they did have a lower incidence of major adverse kidney events. So that gave people like a little bit of food for thought. It's not a really great study. I cannot extrapolate to my ICU patients, but potentially I could start thinking along, maybe we should do more studies for the critically ill patient. And so study limitations, like I said, the patients got a liter of fluids in ED, no further evaluation of fluids after they were admitted. And so most patients who were allocated, for example, balanced solutions, only 83% of these patients actually received the allocated fluids. So major trial limitations there. And so they thought only thing they could really generalize is that the patient who's not critically ill, who received fluids in their ED and went to the general floor, there was really no difference between hospital-free days between the two groups. So that our study was LR and normal saline. So they thought maybe we'll get a better study that more reflects our ICU population. And so the SMART study, which came out actually around the same time. So what really happened was that patients who hit the ED, they said, well, are you very sick? Are you going to go to the ICU? If you are, I'm going to randomize you to the SMART trial. If you are not that sick, moderately ill, I'm going to put you to the maybe regular floor. I'm going to randomize you to the other study. Let's just hang on, I'm sorry. Yeah, so the question that was being asked was, does the administration of balanced crystalloids compared with saline reduce your 30-day composite outcome of death, new RRT, or persistent renal dysfunction? So that was basically more outcome-based, and it was a sicker ICU cohort. And so it was undertaken 2015 to 2017. Large group of patients, 15,000 plus, and they were actually assigned to either LR or plasma light. What they did was that once the patient was randomized in the ED, they let them know. So whatever they had done throughout the rest of the hospital stay was going to be the saline, the solution that they were randomized on. Caveats to that was that every month in the different ICUs, the patients were they were going to use like one predominant type of fluid. And so patients who were there at the end of the month into the next month potentially had a lot of crossover and may have received two separate types of fluids. As you could see, median fluid volume was still pretty low, like 1 liter of LR compared to a liter and 20 cc's of saline. But what they did, but these patients were sicker. If you can note, about a third of them was receiving mechanical ventilation, and about 25% required vasopressor therapy at enrollment. So a little bit more reflective of the typical ICU population that we have here. And the study outcomes, again, there was no significant difference really. So slightly lower incidence of major adverse kidney events, but none of them reached statistical significance. And of course, mortality was about the same. But although what they did note was that there was actually a trend to improvement, meaning patients with balanced crystalloid groups potentially could do better. So with all these trials, what we can see is just a favoring of balanced crystalloids, but no really great data to say definitely move away from saline. So that kind of is the salt group. Now we're going to look at the colloid group basically, and that's derived from I find it interesting, it was derived from the Greek word meaning glue. So just thinking of glue in your veins one time is like, that doesn't sound good. But so they really form gummy masses when they evaporated, and that's why they started calling it colloids. And they typically contain gelatin, egg albumin, starch, or dextrin, and they're relatively incapable of crossing a healthy semi-permeable capillary membrane. And the operative word here is healthy. Most of the studies that were done early on in terms of using albumin and starches, they use it in healthy volunteers. That really, what they were able to say was that those intravascular proteins, which are predominantly about 80% albumin, it does help maintain the osmotic pressure in those healthy patients. And using the Stalin's law, it was the main determinant of fluid reabsorption from the interstitium into the intravascular space. So theoretically, the thought was if I use colloids, then I could easily expand my intravascular space. And also the thought process back then from preclinical studies was that albumin was also anti-inflammatory. There was also improvement in microcirculation. And has also antioxidant properties, which are all very helpful in a patient who has, septic shock, for example. And so what subsequently came out later on was that, like I mentioned, these patients were healthy. And of course, you can't extrapolate those healthy patients, observations in healthy patients to a sick patient, whereby they've actually reviewed and reevaluated this whole role of the endothelium and the movement of fluids across that space. From the endovascular space to your interstitium. So if you take a look here, this is basically your intravascular space, and this center part here, what we've now noticed, or it's been around from early 2000s actually, was that there's actually an endothelial glycocalyx layer, which is a wall of membrane brown glycoproteins and proteoglycans on the endothelial cells, which are pretty much mostly responsible for maintaining that intravascular colloid pressure and the movement of ions and water across into the interstitium. That layer in panel A is pretty intact in your healthy patient, and that's why they had all those great observations that, hey, maybe we can use colloids. If you look at panel B, this layer is damaged from inflammation, which is typically what happens in inflammatory conditions on your patient who's, of course, in septic shock. So basically, the whole argument that you can increase intravascular oncotic pressure in your septic patient, that's not going to hold. And so you will have the same incidence, or a little bit lower, but definitely you have fluid moving out of the interstitium causing edema as well. So like I mentioned, loss of glycocalyx layer and disruption of that architecture results in albumin loss of up to 300% during critical illness. And so volume expansion benefits, which they thought would be great in the healthy patient, they're typically absent in septic shock. It still didn't deter people from looking at, why don't we use starches and what have you in clinical practice. So from early 2002, there was a septic shock experimental model, in rats really, where they provoked, E. coli bacteremia. And they looked at it and said, well, if we use heterstarch, compare that with saline, are we going to get any improved outcomes basically? So what they noticed was that there was less metabolic acidosis and increased survival. So they thought, if it happens in rats, maybe we can check in humans. Would that be something that would help? So they also noted around the same time that brain dead kidney donors, they expanded the volume with colloids. And what they noticed was that in those patients who received those kidneys, something developed AKI. And so that's why prompting the whole, let's think about doing some studies for patients who we can volume expand with starches, for example. So there's a 2001 French study which started out using heterstarch 6%, which was very heavy, like 200 kilodalton, with 3% modified gelatin. They looked at the outcomes in renal function in patients with sepsis. And so what they noted from way back then was that it was an independent risk factor for AKI in patients with sepsis and septic shock. There was another German study around the same time, or a little bit later, 2003, which showed that there really was not a whole lot to gain from using heterstarch. And that study was actually stopped early because primarily it was a study looking at hypoglycemia, glucose control in patients with sepsis. So what they noted, which we already know, is that type control can result in hypoglycemia. So that study was stopped early because of that. But if you look at the percentage of patients who received heterstarch who developed AKI, that was pretty high. And so they said from way back to 2003 that heterstarch is harmful due to AKI. But if you still look back at our sepsis guidelines in 2008, it still says here you could administer either crystal or the colloid for resuscitation grade 1B recommendation. So it was still there in everybody's minds. Well, can we still use starch? And so we started looking at starch a little bit more. And so that came the 6S trial. So it's a Scandinavian starch and sepsis and septic shock. So 6 S's. And so that trial was a big Scandinavian trial. What they did then, if you look back at the earlier studies of heterstarch, they used a lower kilodalton, a lower weight, molecular weight. So that one is 130. They thought maybe the other one is too heavy. So let's use 130 kilodaltons. Maybe that might do the trick. And so they used that compared with Ringer's acetate, and that was basically in 26 ICUs out in Scandinavian countries. And so just to skip forward, a study, when you compare that with Ringer's lactate, volume resuscitated has in patients with sepsis actually resulted in increased risk of death and renal dysfunction. So we kind of knew that from there, but I guess we still wanted more data. So we thought maybe we let Australia do their own study. So we went from Scandinavia, we went down to Australia and said, let's do the same thing again, same heterstarch, but now they said, let's compare it with saline instead. And so primary outcome was, of course, all-cause mortality at 90 days, and they still looked at renal dysfunction as a secondary outcome. That study enrolled about 7,000 patients between 2009 and 2012, and the conclusion was no significant difference in mortality. But if you look at patients, the incidence of renal dysfunction, there was a higher incidence in the patients who received the heterstarch group. And so we started shifting a little bit more. Maybe we can move away from the heterstarch. And so if you look back at these graphs here, if you look at 2007, our resuscitation events, if you look at a study of 84 ICUs, back then, most people use colloids. That dark space here, the majority was with colloids, less with crystalloids. We started getting more data early 2000, so we shifted. Let's use more crystalloids here, less colloids. In the center here, if we were using, for those who use crystalloids, it was basically mostly saline, not so much as a balanced crystalloids. As we go to 2014, that shifted again. We thought balanced crystalloids, that's a great thing, the newest best thing. So let's, jump there. And so you see the incidence of using, so saline use has decreased and we go to more balanced crystalloids. And so that graph also showed that we were using less heterostarch, but more albumin. And so the albumin studies came about, and I guess I should hurry up because it's late. So, so that first study was with 4% albumin. How can we use this in a heterogeneous ICU population? So a bunch of, septic shock, and, whatever came around in ICU. New Zealand study, what you did note, that safe trial, similar rates of death, similar rates of organ dysfunction. So no difference really in whether you use albumin versus saline in that heterogeneous ICU population. So basically similar outcomes. What they did note was an increased risk of death in patients with traumatic brain injury. So that's where this call came about. Don't use albumin to expand your patient with traumatic brain injury. There's an increased incidence of coagulopathy, among other things, and increased intracranial pressure. In a subset of patients who were in sepsis, last septic shock, they actually had lower adjusted risk of death. And so because it was underpowered to actually evaluate this population, they thought maybe we should look at albumin in just septic shock only. And so we have the Albios trial. Looking at that trial, it was actually pretty good. It's an Italian trial, but it wasn't really geared to using albumin to resuscitate patients. What they did was patients who came to the ICU and they thought, well, you're going to have an increased mortality risk if your albumin is low. How about we, replace your albumin or make your albumin go above, 3 grams? Maybe you'll do better. So that's kind of what the premise of this study was, but they were able to extrapolate data with data in terms of looking at survival on patients who actually received colloids, albumin compared to crystalloids. And they found no difference in mortality, but they noted that there was a net lower fluid balance for the first 7 days for patients who received albumin, and there was quicker resolution of shock. So albumin kind of like started making it on the, coming up on the scene as maybe we could do a lot more albumin. And so this was just another study that looked at albumin for large volume resuscitation, again, associated with lower adjusted hospital mortality, but this was just an observational study. And so they thought maybe we could, so more studies are needed to see whether albumin has truly improved better outcome in septic shock. But for the meantime, what we can deduce about albumin is that it reduces the volume of fluids administered in sepsis and septic shock, no conclusive mortality outcomes. Hypoalbuminemia, of course, has worse outcomes in patients with who are critically ill, but if you replace it, it does not improve the outcomes. We still need the albumin, of course, to replace for large volume after large volume paracentesis. If you look at resuscitation after large volume paracentesis, we compare albumin with saline, the outcomes are actually the same, except the albumin group, you're going to have less requirement for vasopressin, early resolution of that hypotension. So with all of that, we move fast forward a little bit. Well, that's gone already, but 2016, surveillance sepsis guidelines said, well, fine, maybe we'll take out heterostarch. And so they will still say the recommendation is based on strong quality evidence, high quality, based on strong recommendation, high quality of evidence, do not use heterostarch for your patients in the ICU. We suggest you can add albumin when you have a large volume of resuscitation is required. And we suggest balanced crystalloids, weak recommendation, low quality evidence. So crystalloids, of course, are still the recommended fluid of choice. So there's no conclusive, yay, go for your balanced crystalloids. But there's already a trend towards using more balanced crystalloids, which is going to help in terms of reducing the incidence of metabolic acidosis, renal dysfunction. And be careful, of course, with your balanced crystalloids, because these studies have shown that it can actually cause more metabolic alkalosis in the patients, particularly, again, with large volume resuscitation. This is really all I have, but I wanted to distract you with this beautiful picture of this beach at my home. So. Okay. No questions? Okay. Oh, well, thank you. I didn't feel like it, but thank you. I was trying to rush through things as well. Okay.
And then we'll just see if there's any questions in the text box.
Oh.
It doesn't look like it. So.
Okay, well, tell them thank you.
Yeah.
I feel like I wanted to be a little bit more in depth, but I know the time was against me. So.
That was great.
Thank you.